Tachycardias are always due to an SNS stimulation. So we talk about SNS stimulants and ABGs and respiratory, right? So it's the same thing. It's always going to be the same thing that stimulates the SNS. That's a normal physiological response is when I have a low O2, a high CO2, a low pH, someone's moving me in bed. These are all things that are going to stimulate my SNS to fire off. Right? My SNS has little closed circuit TVs. They have little Apple AirTags out in the periphery, and they're detecting whether there's movement or whether there is a low pH or whether there's low oxygen or high CO2 or low sugar. All these things trigger the SNS, right? And you imagine if you trigger the SNS, it's going to fix those things, right? One thing I didn't mention was low blood pressure as well, right? Your blood pressure is low, your SNS fires off, and it's going to start vasoconstricting with norepinephrine or Levophed, right? So it's going to hopefully raise my blood pressure. But like we talk about shock states, sometimes there's stuff in the way that's not letting my natural response take over. And of course, we got our SNS response on the heart to raise the heart rate as well. When we have a tachycardia, we're looking for one of these things. What is causing it, right? So you could separate it into the ABCs. I haven't really bought this mnemonic just yet, but it kind of makes sense. You got airway, right? Breathing. Are they hypoxic? Is their work of breathing increased? That's low O2 stage, right? That is what's making them, and also it's a lot more movement too. That's what's making their SNS fire off and therefore cause tachycardia, right? C, you can think of circulation. Are they hypotensive, right? Low blood pressure stimulates the SNS, and that makes sense. I'm going to get tachycardic because of it. And then D, you can think of dehydration. I think of that kind of like hypotension in itself. I'm really, really dehydrated, like a burn. Worst case scenario, that's low circulating volume, low blood pressure, and that's going to stimulate my SNS to fire off, right? So drugs, caffeine, you can think of this D as well. So they have caffeine, they have Coke, they have Coca-Cola, they have all these things that are going to, or meth, all these things are going to stimulate the SNS. They're synthetic SNS stimulants, right? Or on the flip side, they're withdrawing from something that is depressant, right? ETOH is a depressant, benzos are depressants, opiates are depressants, and when you take that away, now because the body was the whole time, you're depressed, and your body was the whole time upregulating the excitatory neurons, and now all of a sudden you take away the negative stimulus, now all the excitatory neurons have free reign, right? And now you're tachycardic. And then E, erythrocytes, so like are they bleeding? That's why I lost the mnemonic at this point. But F, you got fever, right? Their white count's going up. They're febrile. This will independently, an inflammatory response also triggers the SNS, right? And hypoglycemic, we mentioned in passing, so your low blood sugar, your SNS is going to fire off and raise your blood sugar. It's going to go to the liver and tell it to break down glycogen into glucose. It's going to go to the fats and make it break down fats into into ketones and sugar for our body, right? And then it also stimulates cortisol to break down proteins and other fun stuff. And we'll talk about that more with DK and such. All right, so then last thing is, holy cow, it hurts. So I have someone that's in pain. Pain can also trigger the SNS. All right, so again, we have inadequate cardiac output. My ANS is firing off because of the SNS stuff. I got some endocrine going on. These are all things that will make me tachycardic. And also medication withdrawals is important as well. So for instance, someone's off their beta blockers, that can cause a rebound tachycardia. Someone is on steroids and they withdraw the steroids, you don't restart them. Will you get tachycardic? Yeah, it's just not something you want to stop suddenly, because then they can get into adrenal crisis, and that causes hypotension, and that could cause tachycardia. So we want to make sure we are not, stopping our medications abruptly. We got to look at their med rec when they come in after they've arrested or whatever it may be, and make sure we're restarting these medications. And Parkinson's meds are something that usually gets missed. That can cause like severe fevers and neuroleptic malignant syndrome. Okay, so your tachycardia on the EKG. So what does it look like? So there's all kinds of different tachycardias that can develop. If you have a healthy heart, it's going to be nice and narrow, complex, and it's going to be fast, right? That's a normal heart, right? And if it's an older, normal heart, you don't want to let the patient stay tachycardic for a long time. You want to try to intervene and figure it out. If it's a young kid, like in the 20s, 30s, we might say, okay, let's work it out. The fever is getting corrected. Maybe it will resolve on its own. But if it's an older person over 60, 65, you don't want them to be tachycardic all night long or all day long. That needs to be intervened upon, all right? If it is sinus rhythm, usually we don't fix the heart rate. We're not going to give like something to lower the heart rate. They're tachycardic for a reason. Either their sugar's low, or their pH is low, or their CO2 is high. There's something going on that's making it fast. So we need to figure out what that is. And then we can do labs, we can do a lactate, we can do things to figure out why are they like this, right? Why are you the way you are, right? So you have to figure out that's what the underlying problem is, and that's what we fix. If they have a fever, you fix the fever, the heart rate gets better, right? You don't like lower the heart rate. It's like, oh, try to mount a response now, right? So you want to make sure that we are fixing the underlying cause, right? Because if it's sinus, it's definitely the SNS involved. And sometimes they do get really unstable, and you will see a rare case where we fix a sinus tachycardia, but usually it's not, it has to be something that we fix first. We try to fix all the other things that we can before we start fixing a sinus rhythm of any sorts. Okay, and then now we're looking at, is it wide or narrow? So we're splitting again our ventricles and our atria into supraventricular versus ventricular rhythms, because we're going to be looking at wide complex tachycardias and differentiating them. So you're going to be empowered to be able to determine, everybody asks whenever someone has a run of VTAC, they always find the person in the unit that can differentiate, is that VTAC or not, right? So now you'll be able to be empowered to know, is this VTAC or is it just what's called SVT with aberrancy, right? And you're going to sound super smart, right? So SVT with aberrancy means it's not VTAC, basically. Okay, it is wide. It is a tachycardia, but it's not coming from the ventricles. It's coming from the where? Supraventricles, or the atria. Okay. So when you have a narrow rhythm that is fast, right? So it's narrow, being a QRS less than 0.12. It is always from the always from the atria. It's impossible for it to be anything else. Okay, so if it's a narrow complex and it's fast, it's always from the atria. It might be regular or irregular, right? So we have a irregular rhythm that's fast. It could be AFib with RVR. It could be A flutter. That's not, it has 1 to 2, 2 to 3, 3, or it has a irregular conduction rate. Okay, like PSVT, for instance, as well. That can also be a fast, narrow rhythm. It came from the atria. Okay, and then we have wide rhythms. So wide complex tachycardias, just so you will find an expert in the unit, but you're also going to always assume it's VTAC until proven otherwise. And then you're going to look at it more closely, and again you can figure out what it actually is. But if it's VTAC until proven otherwise, that means you're doing what? Are you getting the crash cart? Maybe, but if it's super sustained, you might, right? But you're going to go in the room, you're going to check a blood pressure, see how they're doing. If they look super diaphoretic, they're about to lose their pulse. Yeah, you are probably going to intervene a lot quicker. All right, so it's always VTAC until proven otherwise when you have a wide complex tachycardia. So it's fast, and the QRS is what? Greater than 0.12, right? So greater than 0.12 and fast is always VTAC until proven otherwise. Now we're going to prove it otherwise, right? So it can come from the atria, right? What if I have AFib with a left bundle branch block? That's a wide complex, right? And that's supraventricular. What if I have PSVT? Sometimes you develop a right bundle branch block because your AV node can't keep up. It's like, slow down, cowboy, right? So it's like it's like not able to repolarize as quickly as the rhythms are coming through. So they can have this little run of like a right bundle branch block pattern, or a little run of a left bundle branch pattern. Just depends which bundle branch is more active, all right? So we're going to look, when you have a wide QRS, yes, it could be VTAC, or it could be just a supraventricular tachycardia that's being conducted abnormally through the ventricles. Okay, so you have a wide complex tachycardia, what do? You say, are you stable or not? Because again, it's VTAC to prove otherwise. If it's stable, blood pressure is good. Do you have a chest pain, sir? You've been short of breath, sir, right? You're feeling, so chest pain, shortness of breath, hypotension, confusion, then tell me where you are, then that's going to be a stable tachycardia. All right, if it's unstable, we're moving on to probably calling a code, getting some interventions happening, right? Otherwise, we're going to say, is it irregular or regular? If it's irregular, that's not VTAC. VTAC is always regular, except if it's like torsades. But VTAC itself, like monomorphic VTAC, that you shock when someone's really sick, it's usually it's always a regular rhythm. All right, you don't have irregular VTAC. That's not a thing, right? So if you have a wide complex tachycardia that's regular, you're like, well, shoot, look at that go, woo, that's a super regular. That's probably a sick patient, right? So that's a VTAC. And remember, VTAC can have a pulse and it can not have a pulse, right? There's two versions of monomorphic VTAC. All right, so we're looking to see, what's causing that. Is there something structural going on or non-structural, something I can reverse? Did the family come in and give them a little dose of meth? What happened, right? That happens all the time, don't worry. All right, so that's why you got to go through the belongings and make sure their belongings are clear. All right, so yeah, so if it's regular and fast and wide, it could be, VTach. Or it could be just a fast rhythm that's being conducted abnormally. It could just be a bundle branch block, right? But what else? If you have an irregular rhythm that's fast, it's probably we're erring more on, yeah, it could be torsades, worst case scenario, or it could be what's called a SVT with aberrancy, where we're aberrantly conducting this rhythm coming from the atria. Aberrantly means wrong, right? So it's being conducted wrongly because they have a bundle branch block, or they have a bundle branch block that only shows up when they are at a faster rate. Okay, so that's the idea behind aberrancy. Okay, but before we go on, let's talk about torsades real quick. Of course, torsades can happen especially when you have a prolonged QTC. Okay, so measuring QTC is of utmost importance because we give a lot of IV medications, because giving IV medications is the #1 reason why we have prolonged QTs. So we want to make sure that we are assessing QTCs because QTs are not accurate. They're only accurate to do a QT is when your heart rate's 60. That's the only time you can say that is my QT absolutely. But when you have a fast rate, right, it's impossible for you to have a long QT because if you look at the normal QT is yes, less than 0.5, let's say 0.40, right? Normal 0.4 to 0.45. So 0.40 is 2 big boxes, right? So 2 big boxes is already a heart rate of 150, right? So that's including the T wave, including the next P wave. So it's impossible to have a prolonged QT when you measure your QT. It's always going to be shorter when you have a high heart rate. On the flip side, same thing with bradycardias, right? You're always going to have a prolonged QT with bradycardias. So is it prolonged or is it prolonged when it's slow or fast? That's why the QTC corrects out the rate, right? So QTC is always what we're eyeballing to see if that's what's causing their torsades, for instance, right? So measuring QTC, the most accurate way is to measure every 4 hours. We're doing our EKGs, and we're looking to see is this patient have dangerous prolonged QTs. The danger is yes greater than 0.45, but when it's greater than 0.50, that's really where we need to pump the brakes and figure out why is a QT prolonged. What is causing it? Antipsychotics are common causing it, right? We have our antibiotics, antiarrhythmics such as amiodarone can cause it. Right? So we want to make sure we're identifying what might be reversible, right? We're going to take off that medication. Do they really need this fluconazole, for instance, right? Fluconazole or azoles are always azoles to your heart, they're azoles to your liver, and so they are not a great medication sometimes. So we have to see if we can fix them to some other antifungal. Antiemetics, such as, ondansetron and metoclopramide, those guys can prolong the QT as well. All right, so I'm going to be aware of what can prolong the QT and be assessing it. Right, what other things might make me have prolonged QT or cause lethal torsades? And yeah, prolonged QT as well. Ischemia can do it. Got our drugs that we mentioned. Low electrolytes. So high electrolytes cause bradycardias. Low electrolytes cause irritable myocardiums, and it can make our myocardium as irritable as torsades. Right, so low K, low mag, and low calcium. And when you have low mag and low K, which one do you replace first? The mag, right? The mag is a cofactor for every enzyme and protein in the body, including the ion channels in the kidney. So you want, or protein channels in the kidney. So you want them to be activated first. They can hold on to potassium, right? And of course, severe bradycardias are really hypothyroid, really bradycardic. We know the QT is prolonged. The QTC will follow suit. Okay, so SVT with aberrancy versus VTach. So this is where you have a fast rhythm and it is wide, right? So you have a fast, wide rhythm that we want to try to fix, or try to identify at least. And how do you know which one it is? There's all kinds of little criteria that we look at, right? First of all, you look for worst case scenario. Do they have VTach, right? VTach we know is regular, so that's one of the clues. If it's an irregular, it's not VTach. But if it's a regular, fast, wide rhythm, we can say it might be VTach. Let's look a little bit deeper. The next easiest thing I think to look at is the QRS width, right? So how wide is it, right? If it's greater than 0.16, right? What's a normal QRS? 0.12 or less, right? If it's greater than 0.16, the whole QRS, that's you're in VTach territory. You're all the way here in the red zone. You are definitely in VTach situation, right? And there are some situations where it's not like in the gray zone and we don't really know. That's where we actually measure like how long does it take to get from point A to point B. If it takes a little longer, that might be a patient that has VTAC, right? That's called this Brugada's criteria. It's when you're really super fancy pants. You can say, let me pull my Brugada real quick. I'm going to pull up here, and what is that S nadir, right? That's the dip of the QRS segment from the top. So it's like how wide is that? If it's wider than, what is it, point something, I erased it here. There we go. Is it greater than 100 milliseconds or 0.10? That is considered VTAC, right? Another piece for Brugada criteria is also looking at whether the bunny ears, right? You might have bunny ears on bundle branch blocks and such. Whatever you heard about bundle branch blocks, and if it's left or right or this one or that one, it doesn't matter unless you're talking about V1, right? So V1 is, if the bundle branch block, the left ear is bigger. So if we have where's a good example? We have this guy right here. That's a right, but that's a normal pattern. I thought I had a good one. But here's a good one. So you can see how the rabbit ear on the left is bigger. That is a sign of VTAC. If it's on the right, that's smaller, that's a sign of not VTAC. Or, what is it? SVT with aberrancy. Okay. Other things to look at are AV dissociation, right? When your ventricles are going VTAC-y, do you think that it's an atrioventricular normal response? No. So the way you can assess if they have VTAC is their AV dissociation. So we know AV dissociation from third degree AV blocks, right? Where the P wave is divorced from the QRS complex. They're doing their own thing. That's what you're looking for. Is my P wave right here doing its own thing? Yes, it is. It's going at its own beat of its own drum, right? It's not P wave QRS, P wave QRS. It's P wave, and it's all over the place. Like up here is a good example. The P wave is like on the QRS segment. The P wave is like on the T wave. It's where it shouldn't be, right? So that's called AV dissociation, atrioventricular dissociation. Another trick is when you have a 12 lead, you can look for concordance, right? So we talked about discordance and concordance when we talked about our Barbosa or Scarbosa criteria. But for concordance, you're saying, is everything going the same way, right? If everything's going the same way, that is VTAC. Or it can be going the other way as well. But everything's going the same direction. That is VTAC, right? When someone has SP2 with aberrancy, you're going to still see some other complexes that might look the same. They haven't switched axes, right? They're going the same direction. Okay. Axis deviation won't get into, but when you look at axes here, they can see normally it should be going down, right? But when they have a VTAC, it's coming from the ventricles and it's going up, right? So that's something to see if someone has aberrancy as well. Two little more things are they have fusion beats or capture beats. Basically, you've got a sneaky beat right in the middle. Okay. So yeah, so you have a little beat that sneaks on through. That could be a little capture beat, right? So you got to run a VTAC and a little deal that kind of sneaks right in there, a little narrow complex. That is considered a sign of VTAC, right? Another sign is might have like a really weird fusion beat. So that might not sneak through all the way. It might be a big conglomerate of depolarization. Okay, so capture beats and fusion beats are other ways to determine if someone has VTAC with aberrancy versus VTAC. So all these things are signs of VTAC. So that's what we pointed out. We're not going to point out signs of SV2 with aberrancy, but that's worst case scenario that we're always assuming it's VTAC. Let's look to see if we have AV dissociation, concordance, fusion beats, capture beats, the axis deviation. When we learned about that, and on your fancy pants, you could look at the Brugada criteria. Okay, this is something you would pull out when you're looking at all these different. Do any of these things meet VTAC? Then you're done. You don't have to say, oh, but look over here, the bunny ears, right? You could just say, once they meet one of these criteria, it is obviously going to be VTAC. Okay, and then SVT. So we've talked about this more in arrhythmias, but other things to think about for a patient that is really fast rates, right? So this is not, it could be SP2 with aberrancy, but it's someone that has a really fast rate. It could be coming from, and it's narrow, then we know it's coming from where? A fast rate and narrow. Yeah, it's coming from the atrius. It's supraventricular. It's coming from somewhere up above. These are all the different supraventricular tachycardias. And again, this is an umbrella term for all the different rhythms we're talking about up top right here, right? Technically, sinus tachycardia is an SVT, right? It's a rhythm that's fast coming from the atria, right? AFib is a rhythm that's fast. It can be fast, but it's definitely come from the atria. When it's fast, it's called what? It's called AFib with RVR. So greater than 100 beats or 105 in some sources, it's considered AFib RVR. You can have A flutter RVR as well. All right. And then paroxysmal SVT. That's what SVT used to be called, and then they changed it around. So it gets really confusing now because people say, oh, they have SVT. Like, I thought, what? I thought that, so yeah, paroxysmal SVT is where you have a junctional rhythm that is greater than 150, I think it is, right? So you have a really, really fast junctional rhythm. So in junctional rhythms, they have what? They have, or they don't have what electrical activity don't an SVT have, a PSVT? No P wave, right? So sometimes the P wave might be like inverted a little bit, but like with a junctional rhythm, but they have no P wave. It's just a really, really fast junctional rhythm, right? So you have junctional, accelerated junctional, and then you can go all the way up to PSVT, okay? And we have ectopy that can happen. They can have a little run of fast rhythms, and that can turn into a bundle branch block, and now you have SVT with aberrancy, right? But it's just, with a narrow complex or a wide, you can have a little ectopic atrial tachycardia, where you have a rhythm that's coming from that looks different. The P waves look very, very different. So, example over here, we got a little fast run of ectopic atrial tachycardia. I lost it though. So, and this is multifocal, where the P waves look different, but I'll just draw it, I guess, right? So you have a P wave normal like this, and you have a P wave that's a little bit more peaked, and you have a P wave that might be inverted. So you have different P waves, but it's less than 3 technically. When you have 3 or more different P waves, that's called a multifocal tachycardia, atrial tachycardia. All right, so they have a little ectopy, little ectopic atrial tachycardia. There it is, the big mouse cursor. Okay, so the P wave changes shape all of a sudden, and it goes a little run. So like all of a sudden, it's like it's got like streaking across a soccer field. Like, here it go, and it goes really fast, and then it gets shut down by the heart, right? So that's the idea behind an ectopic atrial tachycardia, or they can be multifocal. There's different P wave morphologies. They have 1, 2, 3 different P waves, right? That's called ectopic atrial tachycardia. Sorry, multifocal atrial tachycardia is when there's 3 or more. Less than that is a ectopic, right? And we have multifocal. You have 3 different types, and it's more than 100. That's called multifocal atrial tachycardia. When it's less than 100, it's called wandering atrial pacemaker, or WAP, but that has a different meaning nowadays, unfortunately. Okay, and then we have re-entry tachycardias, which I kind of touched base on. That's where you have an abnormal genetic situation where your rhythms are kind of going back on itself. Okay, so that's where you have this leakage, you could say, or Wolff-Parkinson-White is another example of that. And that's really rare. You'll see in younger people. It'll usually present before 40. There's an example of PSVT. You notice his rhythm just broke. So it was really fast, 180s, 190s, and then just blowing out through the syringe can fix it, right?
Are the re-entry tachycardias not responsive to like adenosine?
I don't believe they are. You have to. There's like calcium channel blockers and such you have to give for those guys. All right. So yes. So we can blow out through a syringe like this, right? That's one of the ways we can fix a patient that has these SVTs, right? Especially paroxysmal SVT. That's going to respond very well to these. Otherwise, might have to give medications, right? So this is all treatment for what's called PSVT, right? So we can do vagal maneuvers. It's the only thing, one of the only rhythms we can actually do something mechanical or some intervention that doesn't require medications, right? Or a non-pharmacological intervention is doing vagal maneuvers, right? So we can massage the carotids, right? So you do a carotid massage on the baroreceptors that are right there, right? And that's going to trick the SNS to think, oh, the blood pressure's super high, stop it, stop it, stop it. And the vagus nerve's going to take over and lower the heart rate, right? So you can have them, you could do this carotid massage only when they are like age less than 45. Or you have a guaranteed carotid Doppler that's been done that doesn't show that they have atheromas that might dislodge because they can then have a stroke on your hands, right? Don't do it bilaterally. That's not good. We still need flow to the brain. All right. Other things you can do, again, you can have them do a Valsalva maneuver here, where they are exhaling against a closed glottis, which is difficult instructions to give to a grandma that only speaks English as a second language. Exhale against a closed glottis, grandma. Exhale against a closed glottis. And she's like, what? Right? So you have to walk them through it, right? then you'll hear people like shouting, like you're taking a bowel movement. It's like, what? Right. So you got to make sure that they are, that's the easiest way to do this is, again, have them exhale through a syringe is an easier way to do it. There's something called a modified Valsalva where you tip them upside down, right? So you have them blow through the syringe and then you tip grandma upside down. Hopefully not a recent hip surgery, but you tip them upside down and then you put them back up and sit them up 30 degrees, and it has a lot better efficacy than just blowing through a syringe, right? Like, it's for your own good, grandma. So these are things you can do or it's recommended to do. What's not recommended to do was phased out in year 2000. The American Heart Association, the great American Heart Association, the very esteemed American Heart Association before the year 2000 says, you know what can break an SPT? A digital rectal exam. So they said, the patient goes to SPT, get a gloved finger, hopefully, and then you're going to do circumferential DRE, and that will break their SPT. That's since been resolved. We're not doing that anymore, right? In Japan, though, school kids, they love to do what's called kancho, right? And that's just something it's like patting people, like, fist bump, but it's like, got you, kancho, and their SPT will break real quick, right? And then what else? We got, if these non-pharmacological measures don't work, we can do adenosine, all right? So adenosine is one of our medications. It's usually one arrhythmia drug, and that is for paroxysmal SVT. It does work. When we give it over here, you can see we had a really fast SVT. We gave it, and it's like turn it off and on again. All right, so you just kind of shut down the heart, and then it hopefully restarts. It might not. So that means you might want to have what at the bedside? A crash cart, right? So crash cart at the bedside. The crash cart has adenosine in it. It also has your way to give the adenosine, which is via a stopcock, right? Adenosine lasts 6 seconds, right? So if you're like fumbling around, you're doing IV push here and it doesn't work, then you go get your flush. I see everybody go, and they try to get the little saline shower coming out, right? That's going to take way too long. So you want to make sure you have everything set up, your flush and your adenosine, and you're going to give it rapid IV push because it only lasts 6 seconds. And hopefully it lasts 6 seconds. If it doesn't, right, it won't, we have to have opportunities to restart the heart. Okay, it comes in 6 and 12, so we start with 6 milligrams first, right? The side effects, you want to let them know that they're going to feel their heart stop. No, I'm kidding. You're going to tell them that adenosine is going to relax everything, right? It's a K channel blocker, right? It's going to, activates all the potassium channels throughout the whole body, not only the heart, but the whole body, right? It's like creating hyperkalemia almost, or actually it's not going to raise the potassium. It's going to cause the effects of potassium going across membranes and across the heart. That causes a bradycardia, right? And hopefully it goes away and now it just restarts. But that's going to do also the musculature of the vasculature, right? So now every vasculature is going to vasodilate a little bit. They're going to feel flushing sensation because their vasculature is dilated closer to their skin, and they're going to get a feeling of warmth and flushing. And the other piece is you don't give this when you have a low blood pressure. That's a contraindication to giving adenosine. Okay, so again, have the crash cart nearby, right? Give it as rapidly as possible, right? Additional things they might do are like ablation therapies. It's something they might do if this adenosine doesn't work. They do a electrophysiological study to go in and burn out the area that is causing the SVT. Other things to do if your blood pressure is less than 90 and I can't give adenosine, I try the vagal maneuvers. The last thing to do is synchronized cardioversion. What can else be fixed with cardioversion is AFib. So we'll talk about cardioversion, I think, on our last slide. All right, so AFib is your most common arrhythmia, or most common SVT when it gets fast, right? So that's the idea behind assessing if the rhythm's too fast. That can reduce ventricular filling and cause us to have a low blood pressure. So we're always being alert to what the blood pressure is. The blood pressure is less than 90. We have to switch already to what? Doing direct electrical cardioversion, right? Otherwise, we're thinking A, B, C, D, E for a patient that has a AFib. We're thinking of anticoagulation, especially if chronic AFib. And what is chronic AFib? It's 2 days worth, right? So 2 days is chronic, right? So if you have chronic AFib, you don't let AFib go more than 2 days, basically. So like 24 hours and it's like not resolving, it's probably a good idea to start your anticoagulants then. Which anticoagulants? Not warfarin, all right? That's an older drug, right? So we probably want to start something like our factor Xa inhibitors, apixaban, rivaroxaban. These guys are used for anticoagulating someone that has AFib. So they don't form emboli, right? And the emboli can go to the to the lungs, cause a PE, or they can go to the brain and cause a CVA, right? And then what else can happen? We can have, and it really can go anywhere. It can go to the kidneys, it can go to the mesentery, cause mesenteric ischemia, go to the left arm, cause left arm to die. There's all kinds of things that can happen with AFib and why it's important to anticoagulate them. And then bringing the heart rate down. So B for bringing the heart rate down, because these are all of our meds we talked about, ABCD drugs, right? So ABCD drugs, again, amiodarone works on atria and ventricles, beta blockers, and it's only what are called the man babes, and we'll talk about this more with CHF. But C for calcium blockers, only 2 of them, the non-DHP ones, which we'll talk about. Those verapamil and diltiazem, just those 2 will lower the heart rates. The other ones raise the heart rate, so that's not what we want with someone with AFib RVR. And then bringing down the heart rate, then C is catheter ablation, where they go in and, again, electrophysiologically, they go in and they cook the part that is broken, right? They just say, hey, I appreciate your efforts of causing AFib, but we are going to burn you alive now, all right? So that is that we're going to cook out that tissue at 95 degrees and cause that tissue to scar over, so it's not an ectopic site for AFib, right? And then DCCV, or direct current cardioversion. That's used for someone that is very, very symptomatic, because someone can be symptomatic and we can try beta blockers, we try calcium blockers, but if someone's blood pressure is less than 90, that is the linchpin that tells us that we need to do cardioversion, right? This usually happens to someone that's AFib RVR. And why are they in AFib? It's because this atria is like getting stretched out this way. All right, it's getting stretched out. Again, it's usually used to the impulse coming from the SA node, but then all of a sudden the RA gets stretched and it doesn't get its impulse. Like, what about me? And it's going to send its impulse as well, and they're going to fight, right? They're going to fibrillate. So all those things are trying to hit the AV node, and it might be multiple sites, and then the AV node is like, what the heck? I'm trying to hold back all these impulses, and eventually it can't. Right? So we give these ABCD drugs to help HODOR out, to hold the door, so that we can prevent this, all these impulses from getting through, all these abnormal impulses. All right, so again, our treatments are ABCD. All right, so we kind of touched on this already. There's like a summary of all of our tachycardias, right? You give just straight up sinus tachycardia, and do you treat sinus tachycardia? That is not something that we're going to fix. We're trying to figure out the underlying rhythm and why they are tachycardic. Do they have a fever? Are they hypoxic? Is their pH low? They have lactic acid building up? They have DKA happening? These are all reasons for a tachycardia. And if someone has a diseased heart, that's also going to cause tachycardia, but an abnormal tachycardia, such as AFib RVR or A-flutter, or even V-tach for that matter, right? And again, we have to figure out, is this medication going to work good for them? So amiodarone and lidocaine for ventricular rhythms, and our ABCD drugs for anything that's supraventricular. And how do we know it's supraventricular? 100% you can say it's supraventricular if what's the case? If it is a narrow complex, right? A narrow complex, it is a supraventricular rhythm. It could be narrow and regular or narrow and irregular, but either way, that is 100% supraventricular. If it's wide, we always assume what's the worst case scenario? That is VTach, right? So it could be irregular and wide. That's probably not VTach, but we'll look at those things. Okay. So these are all the things that will the treatments that we give for tachycardias are to figure out, is it what's going to work best, and that's why amiodarone you see a lot, because it works on both the atria and the ventricles. All right, so our last slide here, defibrillation and cardioversion. When is this done? When they are symptomatic, right? So chest pain, shortness of breath, no, not really, but when they start getting hypotension, that's the key. That's when the blood pressure is less than 90. That's when we need to step in and do cardioversion, right? There are 2 flavors of cardioversion. They're synchronized and unsynchronized, right? So here's synchronized on the left, unsynchronized on the right. The only time you do unsynchronized is when you have what? When you haven't a pulse, right? So when you have no pulse, that's when you do unsynchronized cardioversion. It's only for 2 rhythms. Which 2 rhythms? VTach and VF, right? Technically, VTach has 2 flavors, it has torsades and monomorphic, but yeah, VTach and VFib, we shock. If it's anything else and it's unstable, blood pressure less than 90, we are going to do synchronized cardioversion. What if the blood pressure is 0 and it's something else? Can I shock them still? No, that's called PEA, right? So we don't shock PEA. It's not going to work. Okay, so sometimes it's elective. Some people sign up for this. I don't know why they would, but it is. They found that with AFib, it's not effective. Like I think it's like 30% of the patients will just jump back into AFib anyways. So why even bother, right? But there are some reasons to like if someone has like PSVT, sometimes we'll shock them out of it. All right. So if they have synchronized cardioversion, the way you know it's synchronized because it says sync, right? It'll say sync on the screen. You'll see little indicators that will tell you that it's synchronized. The reason why we don't just hit shock is why? Because a R on T phenomenon, or that's not it right there actually, but you'll see a shock on the T wave, and that will put them into torsades, right? This patient was successfully defibrillated. They had VFib, and they were shocked out of it and had a resuscitative ROSC, right? If they had no pulse, which they likely did. Okay, some different steps you want to make sure are happening. Make sure you are, you're charged. Set the joules, right? Usually you start at like 120 with our biphasic monitors. You charge it, and do you just hit shock? No, you got to make sure everybody's clear. Otherwise, someone's going to go into a first-degree block on the that's bagging or whatever it may be. All right. So you want to make sure that we are, everybody's clear, and then you can go ahead and shock the patient. All right. And then what happens right after that? It depends, actually. So if it's unsynchronized cardioversion, you're doing it because they have VFib, VTAC, you're immediately resuming CPR, right? But if it was someone that was unstable, you're going to reassess how they're doing. Did it change the rate? What was the outcome? Okay, so these pads, the Zoll pads, will deliver the shock for us. You can put it like this. That's fine, but usually put it on the front and the back. Okay, so what else? So the cardioversion, again, it's for an unstable rhythm, and that rhythm can be VFib, VTAC, or it can be a really fast tachyarrhythmia. And how do we know it's unstable? Is they have hypotension. That's usually why we are going to switch gears from medical therapy to a shock therapy, right?
Doc, why isn't my heart rate coming down? You already have me blowing through straws like an idiot. Then you almost drowned me in a bowl of ice water. Now none of the medications are working. So how are you guys gonna get my heart rate down?
You gonna tell him?
Tell me what?
We're gonna have to electrocute you.
You're gonna do what?
Honestly, it's the only thing left to do, and I'm pretty sure we got it down by now.
What do you mean, pretty sure?
Well, I mean, we shocked that guy in the P wave, and then that guy, we shocked him on the T wave, and then, this dude back here, we just closed our eyes, pushed the button, and hope for the best.
It wasn't the best for him.
But we're gonna shock you on the R wave.
Guys.
I mean, R's gotta be for right? It's gotta be.
Guys.
Wait, doesn't wrong start with R2?
What?
I don't know. Anyways, clear. Maybe next time.
I think I peed myself.
Yeah, that happens.